All right, we would like to welcome everybody. Thank you so much for joining our webinar. This is Exploring the Connection Between Caregiver Mental Health and Early Childhood Development. We're just going to give everybody a few seconds to start to join, but then we're going to get moving because we're really excited about the incredible presentations and discussion that we have planned here today. So we want to make sure we have as much time as possible. So again, for everybody just joining, thank you so much. We'd love to welcome you to this webinar, Exploring the Connection Between Caregiver Mental Health and Early Childhood Development. All right, great. So I'd say let's get started. So quickly, I'd love to introduce myself and the Education Sector Program at IPA. My name is Sarah Cave. I'm the Program Director for the Education Sector Program. And I, along with my colleague Maria Jose Torres, are the hosts for today's webinar. Again, thank you so much for joining us. We're really excited for the opportunity to convene and host this really exciting session. Caregiver mental health is a topic we've been interested in for some time, and it relates to a lot of different initiatives and projects across IPA. So we're really excited to introduce to you the particular community of practice that this webinar is a part of, but then also draw meaningful connections to other work across IPA, including our Two Generation Initiative and projects across our country offices. So again, thank you so much for joining us today. We're really excited. This is our webinar on the connection between caregiver mental health and early childhood development. Just some quick housekeeping about the run of the webinar today. Please feel free to submit any questions or comments or discussion points through the Q&A function. So you can see it at the bottom of your screen or in the Zoom interface. It's a little comment bubble with a question mark in it. We will be curating that flow of questions throughout the webinar. So feel free to include it during the presentations or also once we get to the discussion section. If there are any general questions, we'll try to answer them on a sort of as needed basis as they come in. But then also we will be curating those questions for the discussion section at the end of the presentations. We also just want to make sure to note that the webinar will be recorded and added to IPA's website together with the slides. So if you'd like to follow up or share the presentations from today, please, we will follow up with the email address associated with your registration to share those resources. So again, thank you so much for joining us. Just to quickly go through the agenda. We're going to start with this introduction, just quickly to introduce IPA and the Education Sector Program as the hosts of this webinar, and then the Thrive Through Play Community of Practice, which is the sort of immediate audience and initial motivation for hosting the sessions today. We'll focus on 3 research presentations, so that will be the panel, and we're really excited. Again, thank you so much for joining us. We think we couldn't be more excited for this discussion and these presentations. Then we will follow the research presentations with 2 representatives from the Thrive Through Play implementing partners. So this is the community of practice that is hosting this webinar. And then we will allow for open discussion using the Q&A questions that have been submitted over the course of the presentation at the end. And so with that, I would like to hand the webinar over to my colleague, Maria Jose, to do the continued introduction and move forward with our webinar for today.
Thank you, Sarah. Thank you, everybody, for being here. We're super excited. So first, let me tell you a bit about what is IPA. Some of you might know, but at Innovations for Poverty Action, we believe that research and evidence can serve as a guide to help us do more good in the world and improve the life of people living in poverty and adversity. So within IPA, we work across different sectors and fields of research and policy, and IPA sectors in particular, these 11 that you see in the screen, are topic areas where IPA has built a portfolio of projects and has dedicated staff in subject matter expertise. And this is where Sarah and I sit within the education sector. So within the education sector and in IPA in general, we're continuously seeking new research to inform implementers and policymakers in their design and decision making. We focus on connecting researchers, implementers, policymakers in advancing our mission of effectively reducing poverty. And one topic that emerged in our work with implementers is the relationship between caregivers' mental health and early childhood development. As we hear about this emerging research, you'll see that there are mixed findings, and there are questions that are still to be answered. So the topic of this panel began with a question of how can we support children's mental health and socio-emotional well-being, and whether play could help in this vision. The desire for children to thrive, being affected by conflict and crisis, gave birth to Thrive Through Play. Thrive Through Play is a consortium of 5 implementing partners and IPA, which is a learning partner within this consortium. The 5 implementing partners that are part of Thrive to Play are scaling up play-based mental health and psychosocial support programs, or they're integrating play within their MHPSS approaches. They work across different areas of the globe, mainly focusing on the Middle East, Uganda, and Kenya, and with children of different ages and with different approaches. But they all have one single focus, that is using play to improve the well-being of caregivers and children. So to understand this very, very complex relationship between caregivers' mental health and child development, today we have the pleasure of having 3 great panelists presenting the research. So we have Jiang, who is a doctoral candidate in health policy at the University of California at Berkeley. We have Andres Moya, who is an associate professor in economics at Universidad de los Andes. And we have Dana McCoy, who is a Mary and Max Cargrim Associate Professor in Human Development and Urban Education, Advancement at the Harvard Graduate School of Education. And we also have the pleasure of, after hearing from our panelists about the research, we will have the privilege to hear from 2 implementation experts from the Thrive to Play community of practice, who are going to help us reflect upon how this research is actually landing in practice. Lawrence Agumon is an education specialist for Right to Play in Uganda, and Herbert Barraza is the monitoring and evaluation lead in the Family Reproductive Health Department of AMREF Health Africa. So with no further ado, I leave you with Chi.
Thank you for having me. It's my pleasure to introduce our research on caregiver mental health and early childhood parenting interventions. Let me start to sharing my screen. It's good.
Perfect, thank you.
So today my topic is focusing on caregiver mental health and early childhood parenting interventions in rural China. To brief introduce the background, in rural China, early childhood parenting intervention, early childhood developmental delays and caregiver mental health challenges are both prevalent. According to a meta-analysis were conducted in 2021, there are about 45% of children under age 3 were at risk of cognitive delay, and 46% of them were at risk of language delay. In the meantime, about 25% of caregivers, mothers or grandmothers, reported depressive symptoms, and 29 reported anxiety symptoms. There has been an increasing number of early childhood parenting interventions conducted in rural China. However, caregiver mental health remains understudied. Today, my research question is, how does caregiver mental health shape early childhood parenting interventions? I have 2 specific questions to answer. First, how does early childhood parenting interventions affect caregiver mental health? And how did caregiver mental health moderate the effectiveness of parenting interventions on child developmental outcomes, and why? The study I shared is conducted in 100 rural villages of China. You can see the location and a picture of one of our sample village. These villages were primarily mountain areas and from a previously nationally designated poverty counties. The study was a clustered RCT with 50 villages randomly assigned to the treatment group and 50 villages randomly assigned to the control group. And children aged 6 to 24 months old and their primary caregivers were recruited in the study. After 1 year intervention, there were 40 caregiver child diets were remained in the study. The intervention is a 1 year parenting center at each treatment village. The parenting center is uniformly decorated with free play area with children-friendly decorations, toys, and children's book. You can see one picture from the center. The center opened 5 hours a day and 6 days a week, and caregivers were welcomed to attend the centers anytime with their children. There were weekly one-on-one parenting sessions delivered by community health workers with curriculum adapted from Reach Up and Learn. The village peer mothers also organized group activities every week. However, the center itself does not have any mental health component by design. We have completed the evaluation and there were significant effects found on child development index and simulating parenting practice about this center. So first, what are the effects of those parenting centers on caregiver mental health? Overall, we found no significant effect on caregivers' depressive, anxiety, or stress symptoms from these parenting centers, but there were some heterogeneous effects emerged. Specifically, the parenting center decreased depressive symptoms among caregivers from higher asset household, but increased depressive symptoms among those from lower asset household. In the meantime, the parenting centers increased anxiety symptoms among mothers, but with no effect among grandmothers. And then second, did the caregiver mental health moderate the intervention effect on child development outcomes? We found yes. So the first panel of the figure shows the parenting center improved child cognitive development only among those children with caregivers has no depressive anxiety or stress symptoms at the baseline. And then if their caregivers have those symptoms, those mental health symptoms at baseline, the parenting centers have no effect on children's developmental outcomes. And the panel B is the same, but for language development of the children. Then, how did the caregiver mental health moderate those intervention effects on child cognitive and language development? First, we found that the intervention compliance is not the reason. Specifically, there's no differences between caregivers with mental health symptoms as baseline and the caregiver without those symptoms at baseline on the center attendance. You can see is the is the center attendance bad depressive symptoms, anxiety symptoms, stress symptoms, and or any of those symptoms. But we found the caregiver mental health symptoms did moderate the intervention effect on simulating parenting practice. Specifically, these figures show that the parenting center increased playtime investment and play materials investment among caregivers who didn't report mental health symptoms at baseline and have no effect on those who reported mental health symptoms. Finally, the intervention improved parenting beliefs of caregivers, regardless of their mental health symptoms at baseline. Those parenting beliefs, asking whether they believe they think in simulating parenting practice is important or is their responsibility to interact with their children. Okay, to conclude, we found parenting interventions without a targeted mental health component may not improve caregiver mental health and sometimes may even have unintended adverse effect on their mental health outcomes. And children whose caregiver didn't report mental health symptoms improved developmental outcomes, whereas children of caregivers with mental health symptoms did not benefit from our parenting center intervention. And those effects appear to be driven by differences in the adoption of simulating parenting practice rather than the center attendance or parenting beliefs. So this funding called for greater investment in promoting caregiver mental health as a critical component of early childhood development interventions in low and middle income countries. Thank you.
Thank you so much, Chi. Now I give the floor to Andres Moya, who will be eh, telling us about his research in Colombia.
Thank you, Maria Jose, and thank you, Sarah, for organizing this. And it's a pleasure to be here, to be able to share a little bit of our work and to share the stage with she and with Dana. And I'm going to talk about a little bit the link between caregiver mental health and early childhood and in the specific context of conflict-affected settings, displacement, and I know that many of the organizations here in the consortium are working in these type of settings. And although this is a specific type of setting, I think it has some lessons that actually build upon the previous presentation. So let me jump in and just highlight some things that we already know in terms of conflict and displacement are a global development challenge. There's 2 billion people right now in the world living in conflict-affected settings, and approximately 17–18% of children under 5 are living in these type of settings. And so this bears to mind the question of what does it mean to be born and raised in conflict-affected settings. And there's a nice review paper published last year by Michael Plus and Catherine Penter-Brick in Nature, showing that literature the evidence starting to emerge, but actually there are large gaps in our knowledge in terms of what does it mean to be born and raised in these type of settings. This is showing you kind of a snapshot of what we've learned in Colombia. This is plotting, the figure is plotting the just simple descriptive statistics of social emotional learning, anxiety, depression, and mental health of children not born in conflict-affected settings in Colombia and children who are born in displaced families. Some of these children did not experience displacement by themselves. Maybe they were born a few years later, even a generation later. And we could see very clearly are these very large gaps in terms of social emotional development, in terms of anxiety, in terms of depression, and overall mental health. And this is, in some sense, it's highlighting the seed or mechanism for the intergeneration transmission of poverty and also of trauma. Now, what do we know about the science of early childhood? Well, I don't need to maybe mention this, but early childhood is the most important, the most magical stage of our life. It's also the most sensitive to stress. And so when children are experiencing stress, specifically persistent adversities, coupled with a deficit in sensitive, predictive, healthy caregiving, this gives rise to the overactivation of different biological systems. This sometimes in the literature has been referred to toxic stress, but this is going to affect brain architecture, as the figure in your right is showing. It's going to affect skill acquisition. It's going to affect physical mental health. And this has a risk of having life-altering effects. Now, we know from the literature that the capacity to provide sensitive care, healthy attachment, can actually break toxic stress, can lead into tolerable stress, can actually buffer children from the effects of adversity. But I think, as she was mentioning, we don't kind of recognize that still there's a long way to go to try to understand kind of the conditions in which caregivers can actually connect with children in a proper, healthy, sensitive caregiving and can support healthy emotional co-regulation. And to some extent, we're kind of asking too much of caregivers when we expect them to provide this type of care when they're also going through a lot of adversities. And this is just a picture documenting some of the tracks of Venezuelan refugees going from Colombia to Panama to the Darien Gap. And the picture is saying a lot. And the image portrays a lot of what I want to highlight here. It is very difficult for caregivers going through conflict, displacement, trauma to be able to respond emotionally to respond healthy and provide healthy nurturing care. And let me give you a little bit of how this looks in Colombia in our work in Semillas de Apego. One, conflict has a severe effect on caregivers' mental health. The incidence of mental health problems in conflict settings are between 4 to 5 times higher than in non-affected settings. And what this figure is showing is kind of this dose-response relationship between the severity of violence or the number of violent events that caregivers have been exposed to and mental health. And what you can see is this very clear gradient in which more violence implies poor mental health. And then what we see in our research is also that caregivers with a higher risk of mental health problems or more symptoms of mental health problems are also unable to connect with their children in this kind of healthy, nurturing care, sensitive caregiving. What the figure is showing is in the x-axis, I'm plotting the caregiver mental health index. And then what I'm plotting is also on the y-axis is the relationship quality. And then you can also see this gradient. What does trauma do to people? Well, it hinders their capacity to identify others' emotions, to respond to others' emotions. And this is going to happen within the household. Then the relationships are characterized by either excessive control or fear or by emotional control. They're also characterized by a lot of unpredictability, a lot of uncertainty. And children at the young age require actually the opposite. They require a lot of certainty. They require a lot of predictability. And so trauma and emotional health problems are going to hinder this capacity. And this connects with the results that Shai was mentioning before. For caregivers who are experiencing mental health problems, then they are unable to connect with children in sensitive caregiving. And this is going to disrupt emotional co-regulation, and the consequences are very clear here. Children of caregivers who have higher symptoms of mental health problems then have worse early childhood development. And then this is, again, highlighting the mechanisms of the intergenerational transmission of poverty and trauma across the course. Now, in some related work using the same data, but in a more econometric specifications, what we find is that the effect of conflict of children is largely mediated by what's happening in caregivers' mental health. Unfortunately, and again, as she was mentioning, this has been a missing link. Standard programs have ignored caregivers' mental health. The most successful programs as Reach Up and the implementations like in China, but also in Colombia, in Ecuador, in Latin America, and in other countries, kind of address cognitive constraints, why and how to promote this responsive caregiving, and how to promote this stimulating environment, for instance, through play. But they largely ignore and they have missed the importance of caregiver mental health. In a review that was published 3 years ago of around 500 impact evaluations of early child development programs, only 12% were measuring caregiver mental health. And what they did so was to try to identify kind of heterogeneity of impact. And this is just highlighting how caregiver mental health has been largely ignored. I think I'm running out of time, but maybe to wrap up in the next 2 minutes, let me give you a little bit of a glimpse of what we do in Colombia with Semillas de Apego, which is this psychosocial community-based program. And we gather caregivers in conflict-affected settings, Venezuelan refugees, IDPs, for 15 weeks, groups of 15 to 20 caregivers. This is a community-led model, and we target first caregiver mental health as an important outcome by itself, but also as a pathway to help caregivers connect with children in a better way and reframe the experiences of conflict, the challenges of caregiving in these type of settings. Then the model switches into trying to promote early child development through more sensitive, more predictable, more certain caregiver relationships. And they also promote the sense of belonging and collective agency. It follows largely a reflective approach, not an instructive approach, to promote emotional awareness and regulation, to understand that these traumatic responses, that the responses and emotional responses, both in their own well-being, but in their relationship, are normal responses to very abnormal and traumatic circumstances. And in doing this through a reflective approach, caregivers and participants can recognize and reframe these challenges. There's a couple of points that I want to highlight. This is a community and group model, and this is important because it allows caregivers and facilitators to come in at the same level, horizontal relationships. This is important to overcome stigma. This is important to learn from each other, from the facilitators who are experiencing the same things, from other caregivers in the neighborhood who are experiencing the same things, and to create some of these support networks. And what we found in some evaluations, one of which Maria Jose was a big part, is that even in a setting of extreme conflict in which conflict was still happening, displacement was still happening, we were able to promote caregiver mental health. We're able to improve the quality and the type of interactions and relationship between caregivers and the children, and we were able to improve children's mental health and early childhood development. So it is possible. It is possible to change. It is possible to improve the relationship between caregivers and children in this type of conflict settings. It requires taking a step back and also considering the resources, the capacities, not only in terms of information, but also in terms of the emotional well-being of these caregivers. And thank you so much. And this is some information about her. Thank you so much.
Thank you, Andres. And then to wrap up our research presentations, I leave you with Dana McCoy.
Good morning, good afternoon, good evening, everyone. Thank you again for allowing me to be here. It's such a pleasure to join everybody today and talk a little bit more about this very important topic. Let me pull my slides up. So I'm going to build on the themes that Chi and Andres have both touched upon, in particular talking about how these relationships between caregiver mental health and early childhood development are often quite complicated. So the two questions that I will be talking about today are, does better caregiver mental health always translate into better child outcomes? And do interventions to support parent mental health always work? And the answer to both of these questions is no. So we're going to talk specifically about three different studies. I'll go through each very quickly. The first two are large-scale surveys from Ethiopia and Uganda, looking at various characteristics of parenting and child outcomes. And then the last is an experimental study looking at the impact of an intervention, a digital intervention for parents intended to improve both parent and child outcomes in low-income settings in Brazil. So really quickly, this first study from Ethiopia was recently published by Noelle Suntheimer, who I believe is actually on the in the webinar with us today. So big credit to her. This was a large-scale survey with cross-sectional sampling. It was designed to be representative of the population of parents with young children in Addis Ababa, Ethiopia. It included 3,000 households, and the goal of this survey was to collect data for the government to help to inform investments in early childhood development programming across the city, and also to track progress towards achieving better outcomes for parents and children over time. And the goal of this particular study that I'll be talking about today was to really understand the relationships between parent characteristics here, their beliefs about nurturing care, and relevant to this webinar, their levels of psychological distress, how these characteristics shape how they invest in children's learning opportunities within the home through providing materials for learning and actual interactions with children through cognitive stimulation, and then how in turn these characteristics shape children's outcomes. And so what we found when sort of looking in here on parent psychological distress, mental health, is that surprisingly, we did not actually find any associations between parents' psychological distress and how they invest in children's learning opportunities for infants and toddlers. So we expect, of course, parents with higher levels of mental health would maybe have less opportunities to invest. In turn, that might shape children's development in different ways. We didn't see that in our particular study for infants and toddlers. However, when looking at slightly older children, we did see the expected patterns of relationship, where parents with higher levels of psychological distress were able to invest less in their children's development, and that lower levels of investment in turn led to lower levels of child development. So what we're concluding from this first study is that there may actually be developmental differences in how parenting mental health might shape children's development, shape their other sorts of interactions with their children, and so on and so forth. We also kind of replicated this within a sample from Uganda. So in this particular sample, we were really focused mostly on refugee families and host families within the West Nile region. This included a cross-sectional survey of 760 households. These families were all facing pretty extreme levels of socioeconomic disadvantage, in addition to, in certain cases, histories of trauma and migration. We tested the same conceptual model, again, looking at older children and younger children separately, zooming in here on parent psychological distress. One surprising finding was that we actually, although we did find that higher levels of psychological distress were associated with lower levels of learning material in the home, that was expected. This blue arrow was somewhat unexpected. So we saw that caregivers with higher levels of psychological distress in this sample actually ended up interacting with their children more frequently to provide cognitive stimulation. This is a speculative finding at this point, but we speculate that maybe within these contexts of trauma and disadvantage, parents are seeking support from their children or using their interactions with children as a sort of coping mechanism for the psychological challenges that they're facing. That's, again, a very speculative finding, but unexpected at this point. We see a similar sort of pattern in preschool age children, although here what we're seeing is that caregivers with higher levels of psychological distress are enrolling their children in preschool more frequently. So again, this is a sort of an unexpected finding and goes contrary to a lot of the literature, which suggests that maybe in context of extreme socioeconomic disadvantage or for refugee households and host families that are facing lasting trauma, enduring trauma, we might not see the expected patterns that we see in other populations. The last study that I'll very quickly go through is, again, a research study that was looking at the impact of a digital intervention that was added to an in-person home visiting program for low-income families in the state of Ceará, Brazil. This was a cluster randomized controlled trial that included a little bit over 1,100 households, all of whom were eligible for government services and had low levels of income. The theory of change for this program was very similar to what we see in many other in-person ECD programs, where the program was intending to support parents' knowledge, attitudes, and beliefs about child development, as well as their mental health. We specifically looked at depressive symptoms and stress. In turn, we hoped that these changes in parent attitudes and mental health would improve the learning environment of children at home and then improve, in turn, children's developmental outcomes. These findings are preliminary at this point, but what we're actually seeing is, somewhat surprisingly, we're not identifying direct impacts of the digital program on parent outcomes, but we are seeing positive improvements on child development. Now, one thing to keep in mind is that these findings, this end line was measured about 18 months after the start of the program, so it could be that this program was initially improving or changing parent outcomes, but the parents had sort of reverted back to baseline. However, this is surprising, and what it suggests is that we don't always necessarily see impacts of ECD programs through the expected channels by changing parenting behaviors or attitudes or beliefs. We also did some qualitative interviews with the families in this study, and one key finding that came up repeatedly is that the parents in this sample who are low income were really feeling overwhelmed on a day-to-day basis, and this shaped how they interacted with and perceived the program. So, for example, one parent said that the program impacted her positively because it taught us a lot. Like I explained, I had very little patience. I was overwhelmed with everything falling on me. I went through some rough times. But thank God, now I sit down and I play with them. Now I feel more confident about raising my child, about encouraging him. So for this caregiver, she sort of leaned into the program as a source of support, despite feeling maybe a sense of being overwhelmed or lacking confidence. However, there were other cases in which the parents felt so overwhelmed that they couldn't engage in the program. So, for example, I didn't use the program much because I also work, so I don't have much time. Little time I do have is already for household chores. I don't have much time for doing things from the program. So I think this is very similar to some of the findings that Chi was mentioning, where you have different levels of engagement in the intervention, different opportunities to benefit from the intervention depending on parents' mental status and their ability to really take advantage of the programs versus whether the program actually may add more to their plate and make their already challenging lives even more complicated. So in conclusion, I think what I take away from these studies collectively is that mental health, again, is not always associated with better child outcomes. Based on our work, we're seeing differences based on both child age and context, and in particular, in contexts of extreme disadvantage or trauma, caregivers with high levels of distress may actually cope by investing in their children. We also see from this finding in Brazil, but also many others in the literature, that parenting interventions don't always improve parent mental health. This can be true even for parent interventions that benefit children. I think, Andres mentioned programs like Reach Up and Learn. There's many programs out there that are benefiting children without necessarily measuring or identifying benefits to parent mental health. We would speculate, I think, based on this work, that interventions may work better when parents are otherwise not receiving services, or when these programs are specifically designed to ease parents' burdens to address mental health concerns rather than adding to them. So I will end with some quick takeaways. One, and I think the most important takeaway for me, is that caregivers matter. Caregivers' mental health should be prioritized as an outcome on its own for our intervention studies, not just as a pathway for supporting children. So really prioritizing caregiver well-being, measuring it, studying it, understanding it alongside impacts on children should be a priority in the future. Also, I think a second takeaway is that interventions, and this was mentioned before, should be very thoughtfully delivered and designed, prioritized for populations with few available supports, focused on reducing parents' burdens rather than adding more responsibilities, and built to reflect the needs and priorities of the local context. Given what we see in these many studies is that these findings are often very complex, very developmentally dependent, and very contextually dependent. And I will end there and say thank you to all of you, and looking forward to the questions and feedback.
Thank you very much, Dana. And all of you, T, Andres, Dana, for your wonderful presentations and giving us all the nuances on this complex relationship. With that, we start our discussion led by the implementers of the Thrive to Play community of practice. We're going to start with Florence from Right to Play, the Right to Play organization. So Florence, now with you.
Maria, and I want to applaud all the panelists, Dana, Andres, and Jiang, for the wonderful presentations. Once again, my name is Florence Angom. I'm the education specialist, Right to Play. So as Right to Play, our mission is to protect, educate, and empower young people to rise above adversity through the power of play. I've liked all the presentations, and I want to comment that the researches that have been done are highly relevant to our current that looks at emphasizing how poverty, caregiving, limited stimulation in early environments interact to shape children's development. Yeah, so the evidence here, as presented by Dana, reinforces that improving early learning outcomes requires addressing both the quality of the caregivers, the child interactions, and also looking at the broader perspectives, broader psychosocial pressures that are facing the families. And the approach also supports embedding play-based learning within the everyday routines rather than relying on resource-intensive inputs. So as an implementer, it would benefit me from having another additional research on how to sustain the caregiver behavior change in highly constrained environments, and also looking at the minimum dose of responsive interactions needed to see meaningful child outcomes. Yeah, so we want to see that the more implementation should focus more on evidence on scaling the low-cost community-led models that would strengthen our program design. And then as we also look at the contextual factors that are not fully captured by the research, particularly looking at the extent to which the economic hardships, food insecurity, and caregiver fatigue limits parents' ability to consistently engage with the children, even when they understand responsive practices. So caregivers will need to understand the foundational support and encouragement before they can prioritize play and interaction. Yeah. So with this, I want to say that on MHPSS, how it should be addressed. So we want to look at the caregiver stress, for example. So it depends on the caregiver stress and the daily burden, especially in the contexts with the chronic poverty rather than acute trauma. So one see that integrating light psychosocial support within the parenting and early learning interventions, I think would be very effective than having a standalone mental health and psychosocial support. Of course, still while recognizing the caregiver well-being as a central also to child development. And then, on the next presenter, also want to applaud Andres for the great work and to say that, yes, caregiver, the research reinforces that caregiver mental health is foundational to responsive parenting and positive childhood outcomes. And also it challenges the assumption that caregivers are always ready to adapt play-based and responsive practices without first addressing their needs in terms of the high stress levels that they have, the trauma, and then the survival pressures that they experience. So this evidence encourages us to integrate basic MHPSS components, elements alongside the parenting interventions. That's you want to be more intentional about sequencing based on the caregiver's readiness. Yeah, so this will also benefit us as the right to play and the TTP, the Thrive Through Play partners, if we are to know how to sequence the MHPSS vis-a-vis the parenting support effectively, particularly in our context in the refugee settlements that we're currently implementing on, and looking at that, the low intensive MHPSS models that can be easily delivered by community facilitators, considering that the capacity and the level of education for the facilitators, they may not deliver really, but we have to see how to really have the most simplified models that the community facilitators can be able to work with. And then, so basically the key issues here is at what point should we bring out the MHPSS component? Should we put it that it depends on the levels? Like, for example, in protracted crisis and then in high intensive locations, at what point should we bring in the MHPSS component? So the question is MHPSS a necessary entry point while in more stable settings? Parenting support, can parenting support be introduced earlier with a few elements of psychosocial support, elements integrated into the parenting sessions? And also we should also consider that this will depend on the availability of basic services, availability of social support systems in the highly stressful and displacement contexts. Yeah, so I would really benchmark on all these three studies to improve on the project design. Yeah, so currently we're piloting Ready to Learn Thrive Through Play program that looks at improving children's psychosocial well-being through equipping ECD caregivers, teachers to effectively facilitate play-based psychosocial support in the classrooms. And then also we're working with parents to ensure that parents and children have a very strengthened relationship with their children. That will also ease issues of school readiness, issues of transition of these children. Yeah, so this is very relevant, and it is a take home that will have a further read on the three researches, and then pick out the most important aspects that we need to improve on our current programming, since this is still a learning project, and we're still in the pilot study of, we're still bringing out ideas and refining on how best to support the children and the caregivers. So the beauty about this is it is focusing on caregiver well-being or parent well-being, and yet our focus here, we're looking at child well-being, but with very minimal components on caregiver well-being or caregiver mental health. So that is an area that we need to learn more about and see how best to improve the current program that we're implementing. Thank you so much, and over to you, Maria.
Thank you so much, Florence. I think these reflections from you are gonna really enrich our discussion once we hear back from the researchers. And now I'll leave you with Herbert, who's a representative of AMREF Health Africa.
Yeah, thank you so much. So just briefly from AMREF Health Africa, and received greetings from Kenya. Yeah, I managed to go through these three presentations, and they were quite exciting because the way it approached issues around conflict, because if you see the target groups that we having here in Kenya, we're dealing with refugees who have seen loss, who have seen conflict. They have moved from borders up to the refugee camp, and also there are challenges within this settlement. And also looking at the communities that we are serving, also having a lot of socioeconomic strains at household level emanating from the climate-induced, because we're having very difficult droughts. And you look at urban refugees within Nairobi, whom we're also targeting, the conditions in terms of where they're staying, they're quite difficult. So when I was reading these articles and looking at the findings, especially the way we approach issues around caregivers, it came in strongly that issues around childhood development interventions without those integrated, targeted mental health components are insufficient. So as AMREF, we are known for programming around health. So how are we layering issues of mental health around issues of health? So this has come out clearly on areas that we need to focus on. So looking also at what we currently implementing, just implementing play, joyful play to simultaneously reduce stress and create that positive interaction between the caregiver and the child. And here we've seen from these articles the role of the state of the caregivers in terms of their mental health. So for us as AMREF, what we're doing is especially targeting the caregivers. Just some brief, simple components at the start and also at the end of play sessions, just focusing on caregiver emotional check-ins and stress management. Just looking at the short breathing, exercise, all this gearing to get them to that state that they can focus and also support the children. We're targeting 0 to 3-year-olds, so these are very young children. Yeah, these are preschool children. So how do we use play to prepare them to get to school? So this also has come in strongly in terms of how the mental health of caregivers in preparation, in terms of even equipment, how they approach, especially these young children. So it's areas that we look at reflecting on. So thirdly, we're looking at the human resource that is there to sustain some of these interventions. So at community level, we're looking at the community health promoters who are working within those communities. And why we use this component, and I've seen it in this publication, is that to reduce anxiety, especially for caregivers where it comes in of insufficient. You come into a community, you start introducing this play, you start creating as if that caregivers has been insufficient. Yeah, so using the local materials to develop equipment, using the human resource that is there, has come in clearly to really support this kind of intervention. So lastly, I just want to pose a question also, because looking at the target group that we have refugees, we have households that are facing very strong stress when it comes to economic, poverty levels are high, and we have these invisible borders. You look at culture, you look at gender, you look at safety. How are you putting all this together, and how are all this affecting program delivery, especially when you look at mental health, especially when you look at issues of play for these young children? Yeah, these are very young children. You're looking at protection, you're looking at nutrition, you're looking at other components. So how do you bring all this together to ensure that interventions are very successful? So Maria, I'll stop at that and take it back to you. Thank you very much.
Thank you, Herbert. This is very insightful. I think with both of your presentations, there is a pressing question on how to sequence mental health within the interventions, and mostly considering all the constraints that can be faced in the context in which you implement, where you're not only facing mental health and distress, but also economic distress, climate distress, other health conditions, and where it's a much more complex situation that sometimes we acknowledge, and how can this translate into a program delivery. So I'll leave it to the three of you to answer as you wish. Andres, I see you.
Yeah, so great question, Herbert and Florence, and I think in Semilla de Apego, for instance, in our impact evaluations, I was showing kind of the average effects and how the program improves caregiver mental health, and then through that, how it improves the quality of the relationships and early child development. But we also see, similar to some of the things that she presented, that for households who are food insecure, who are in extreme poverty, the program does not work that well. It still has positive effects, but they're actually lower. And I think this goes precisely into your point, in which we should consider that the mental health is actually responding to many dimensions, but then that it's very difficult for a caregiver who, for instance, is just struggling to bring food to the table on a regular basis, to be able to participate, to be able to have the time and the emotional space to engage with the reflections and the kind of the lessons from this Semilla de Apego program. And so I think this takes you to the broader question of this hierarchy of needs, and how maybe you need to sequence this in terms of creating a secure base of so that families are food secure, and then start bringing in these type of psychosocial and mental health components. I think BRAC has a lot of experience here in terms of how do you sequence this. I think the evidence still out there in terms of how do you evaluate and create this a body of evidence for this dual generation models. And this is the other point that I wanted to raise. You need to think about these dual generation models, in which maybe we can kind of come in at different moments with the different components that we have discussed.
Thank you very much, Andres. Dana or Chi, do you want to also address this point, or should we go into the next question?
I think let's go to the next question. I think Andres did a great job responding.
Amazing. There's a very interesting question here on where do we draw the line between psychosocial support and actually doing therapy, mostly when we're thinking about programs being addressed by paraprofessionals or community health workers.
Should I jump in, or?
I think Chi wanted to mention something.
Yeah, I'm not seeing Chi. Sorry.
Yeah, I think like I'm studying thinking healthy programs a lot. I feel like for like a paraprofessional or community health workers, Sometimes like as specifically for thinking healthy, the cognitive behavior therapy doesn't work, like cognitive therapy specifically does not work well in the field, but a lot of studies seeing positive effects from social support and behavioral activation, which activates caregivers to adopt healthy behaviors and practice works better. Um, so yeah. I think like for the paraprofessional interventions, it has to be very like standard, very specific requirements, and to consider the context. Not like seeing okay, not like seeing like the community health workers to determine how to respond to caregivers based on their responses. Then it will be very hard. Like in our interventions, I think it will be very. I think the curriculum should be very standard and considerate. Um, yeah, I don't. But it's still a question, I think. Yeah. Even for thinking healthy, it's very, very hard to be implemented in China using the standard menu. It's still a question for in the field.
And maybe just to add that I think community-based models, this task shifting approach has like a lot of potential, and I think it goes beyond just being able to overcome deficits in mental health professionals. And as I was mentioning, it creates these horizontal relationships, but there's more connection, more reflection. You're able to overcome stigma. You're able to understand that it's possible to change, that it's possible to learn, that it's normal that you were struggling and like being challenged by caregiving. Caregiving is magical. It's also challenging, even in very. So I have a 10-month-old baby, and it's wonderful, but it's also challenging at sometimes, even if we have like a lot of privilege. And so the community-based models, I think, kind of create this space for reflection. But I think there has to be a line in which when you identify these critical cases of people being at risk, you need to come in with a principle of no harm, and then move into more clinical type of interventions. The challenge, I think it is, and it's in many of our countries and for most affected populations, the capacities are not there. But we need to keep working for this.
Maybe one
Okay.
follow-up question about that I think relates to also issues brought up by Florence and others, and one of the Q&A questions that just came in about income levels of the participants, and one of the questions that Kate just answered in the Q&A as well about, is this program working on average, or is it only working for some individuals? I think Andres and Key, you've both seen results that maybe these programs aren't working for the most disadvantaged, economically constrained households. But then just also in your response too, I think one of the earlier questions about different levels of mental health distress. Do we need different variations of programs targeting, sort of households with a particular profile? Or how do you think about, we're seeing these programs that maybe might have average or not have average effects, but they're affecting different households in very different ways. I wonder if you could talk about that a little bit, and thinking about what is the next step then, program modifications or targeting different households in different ways, and reflecting a little bit on your results about how these programs might be working for some households and not others.
Yeah, this is a great question, and I think when we started, we were focusing on a very particular, and the impact evaluation that it showed was very particular set of population. We're scaling right now. We're reaching 4,000 caregivers across the country in 12 municipalities, and then kind of targeting became very difficult. And now we have Venezuelan refugees, but just very vulnerable populations. And what we're seeing, and this year this happened, was that when participants were food insecure, they stopped participating. But then when they came in, because we provide a snack, it was actually the only food that they were having for the day. And then it was very difficult for them to engage in the discussions. And so organically, what happened was that the team started to adjust to provide kind of a minimum package, but not go deeply into the discussions. And so I think this requires for you to think that a one-size-fits-all program won't work. Then you need culture adaptations. Then you need adaptation for and some flexibility in to do this. Now, this is challenging. You require capacities in your team to be able to read this, to understand this, and to adjust. But I think this is something that we need to think, and not come with a parachute program that is just basically implemented the same way everywhere, because it's not going to work the same for everyone.
I agree with everything Andres just said, and I will add in our own story in Brazil. Is actually we are seeing the intervention that I mentioned that is having the digital intervention that's having impacts on children is actually working better for lower income families in Brazil than it is for higher income families. So it's not always that these interventions don't work for more disadvantaged settings. I think it really depends on the context, right? In Brazil, this is not a setting where there's huge levels of trauma or crisis. The basic needs are being met by social service providers. And so in that context, these additional interventions actually can be equalizers. So this just speaks to the complexity of the intervention world and the need to really unpack the findings, as you're saying, Sarah, to look at subgroup impacts. And then I agree completely with Andres to make sure that we have, when we deliver our interventions, we have the kernels, the core practices that we know are universal and applicable to everyone, regardless, and need to be delivered, the active ingredients. And then also provide customization and flexibility for the implementers to meet the needs of the families of where they are and support them to make sure that we're not providing services that are not useful.
Maybe Key, do you want to come in? And then I think we might start to wrap up. We know we're almost at time, but I think you had some findings on this topic as well. So why don't you come in a little bit and then we can transition towards wrapping up.
No, I just also I totally agree with two professors. Just like one point of view, like sometimes people want to add more components to one intervention or giving them like too many, but like from our finding, it's not always good. Also, like it's very easy to overburden like not only like caregivers but also the community health workers. So I feel it will be very careful to adding like components to the intervention. Um, yeah, I think that's all.
Great. Thank you so much. We are so incredibly grateful for this wonderful discussion, for the great presentations that we had today. T, Dana, Andres. This was so exciting and really relevant. I think we heard in the comments from Florence and Herbert, how immediately thought-provoking and influential, this research is for practitioners working in the field. We want to thank everybody who was attending today online and the wonderful questions that came in through the chat. As we mentioned before, this is recorded and we'll be sharing the slides as well. So look out for that for any follow-up. And that this is also a theme we are really excited in continuing to look at across different research projects and studies. A few of the other comments that came through also relate to, sort of additional topics that we're really excited about. For example, not just looking at mothers when we say caregivers, but understanding different caregivers, whether that's grandparents or fathers or other profiles of caregivers, thinking about the interaction between anti-poverty programs or poverty alleviation interventions and how that relates to mental health and caregivers' capacities. So please stay in touch and follow our work on the Thrive Through Play initiative and other work throughout IPA. Thank you again so much for joining today, and please be in touch. We are so grateful for your participation.